Why isn't ACOG recognizing experts in restorative reproductive medicine and naprotechnology? Why aren't they recognizing all of the research that's been done on that side of the coin?
There is financial incentive in using medication like hormonal contraception that you just aren't going to match if you are saying, we love restorative reproductive medicine and we think that it should be practiced widely and everywhere. What's necessary is for patients to continue to insist and ask questions and advocate for themselves and to say, what else do you have to offer me?
Welcome back to the Truth and Fertility Podcast. Anne-Marie Williams. I'm so glad to be talking with you today because, so I was looking at our last interview that we did, which was almost a year ago. And for anybody who's interested in that, I will link it in the show notes below because it was so good. We talked about postpartum anxiety. We talked about like intrusive thoughts that can come with that and just like the realness of postpartum. So we talked about that last time you were on. So I'll link that in the show notes below for anybody who's interested because that was just such a phenomenal interview. But today we're talking about something totally different. So back in March, I believe, is when you released this article. I was looking through Natural Womanhood, which for the listeners is a phenomenal resource if you are just wanting to learn more about restorative medicine, just root cause treatment for fertility, like literally anything you can think of for fertility issues. Go to naturalwomanhood.org. It's just phenomenal. And so I saw that you had written an article, and I'm actually going to pull it up right here so I don't miss it. Wins and misses from ACOG's new endometriosis guidelines. And I'm like, hang on. ACOG has new endometriosis guidelines. Let's learn about this. So I just want to pick your brain about that and what that means. So I guess my first question I'll throw the first question out for you, but also you can reintroduce yourself for our listeners who are not yet familiar with who you are. So introduce yourself first, and then let's talk about what even ACOG is, just to get that foundation understood.
Sure. Terrific. I am Anne-Marie Williams, and I am a wife and a mom of 5 plus 1 miscarried baby. I have 10 years of experience at the bedside in nursing in the hospital, mostly in the adult ICU setting. And then I was most recently, so I guess, is this a disclaimer? I was most recently the managing editor over at Natural Womanhood, which is why
Yes,
I
that's right.
know a lot about their content, and I also write for them really regularly. But I'm really proud that they are now a wraparound women's health website. And so the goal is that anything you could type into Planned Parenthood's website, you can type into Natural Womanhood and come up with something. And that was during my tenure, my reign, whatever you want to call it. That was during
It's a
that
great
time that
goal.
we really expanded to do that. So I'm very proud of that, and I really do encourage listeners. Yeah, I really respect and admire the work that all the writers do and their current admin team now. Besides being a nurse and then a mom and wife, I also host a podcast, and that's why I spoke to you the first time about a year ago. It's called Postpartum on Purpose. And I just help moms to approach postpartum as a time of grit and growth and grace, and with the possibility in mind that they could love who they become during postpartum, as opposed to looking at it purely as a time of depletion and despair and discouragement. But what brought us together here today was talking specifically about ACOG's new guidelines. And for those who are not familiar, ACOG stands for the American College of Obstetricians and Gynecologists, and it is the professional organization of reproductive health professionals. Um, they have thousands of members across the country, and they put out different levels of recommendations for various reproductive health problems. And endometriosis is one that they had a practice bulletin, I believe, in 2010, and then another type of document in 2018. But there has been increasingly a push for them to release new guidelines that recognize what we have learned over the last decades of research, but especially more recently, about how to diagnose endometriosis and how to treat it. So these guidelines are, they're careful to say, we're not telling you how to practice medicine, but it is sort of their approach to endometriosis, their recommendation. So it's kind of like when you see the medical disclaimer at the bottom of a website that says, this is for purely informational purposes, but this is a professional organization for reproductive health professionals. So people put a lot of stock in what their recommendations are. And The good news, the article that I was writing was wins and misses from ACOG's guidelines. The guidelines are, I believe, about 12 pages long, and the average person does not have access to them. Somebody gave me access to be able to read them and then synthesize them for natural womanhood. But the average person isn't able to look into them so that they can say, oh, like these are the things that are new, these are the things that are different, to even be able to compare to their previous documents. Um, but when you look at them on the whole, one thing that I wrote for Natural Womanhood we really celebrate is the recognition that endometriosis symptoms can show up early, much earlier than was previously thought. And part of why that's great is because we know that in women who have had endometriosis for years and years and years, and it's been undetected and therefore untreated, we know that these women can have significant internal scarring, and we know that it can lead to infertility. And the promise, the hope, the potential of diagnosing that much, 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 much earlier and starting to treat it and help protect the woman's fertility is that we may be preventing infertility down the road. We may be preventing heartache. And that is certainly something to be celebrated. There's an article I'll send you that I had written, or maybe I edited it. It's hard for me to remember what I edited versus what I
You've
wrote.
had your hands on a lot of things, so it's
I've had my
great.
hands on hundreds of articles over the years. So now I kind of think, I don't know if I wrote that or if I just read it. But there was an article we put out in the last couple of years about this exact thing, that endometriosis symptoms can show up as early as the teen years. So we would expect to see a young girl have irregular periods for about the first 2 years after puberty hits. But if she's continuing to have irregular periods for multiple years and they're not becoming regular, and especially if she's having painful periods, then we need to be thinking there's something beyond the pale here. We need to be looking into this. And the guidelines recognize that we need to be aware of this for teen girls. And they recognize that we need to be aware of this for pediatricians, for family practice doctors, for healthcare professionals that come into contact with teen girls, even if they are not in an OBGYN's office. So even outside of a reproductive professional's office, we need to be considering or having a suspicion for the possibility that we're looking at endometriosis. Other things to be aware of that we don't love so much. These clinical practice guidelines have several different levels of recommendations. They have several strong recommendations, they have several conditional recommendations, and then they have several practice points. I think they call them good practice points. And those are good practice points. Yeah. Those are based on different levels of evidence, meaning different levels of scientific research supporting them. But the good practice points are just based on what they say the experts say. They're not even based on research, and that's, or certainly on high quality research. And none of the research that's used to support these recommendations is considered high quality. The best of it is
Mm.
considered moderate, and much of it is considered low quality. So that's something to be aware of as well, that even the things they're strongly recommending are not based on high quality research. And that's going to contribute to something that I'm going to say in a minute. But things to be aware of is just this idea that even the things that ACOG is saying we really recommend aren't based on super high quality research. So, point one to remember, we really like that they are recommending diagnosis or considering diagnosis in teen girls. Point two, we have to remember that their recommendations are not based on high quality evidence. And then three, they have a strong emphasis in the guidelines specifically on diagnosis. So there's much less emphasis on treatment. There's much more emphasis on diagnosis. And that is good as far as it goes, but their recommendation for diagnosis, their top recommendation is the type of imaging, transvaginal ultrasound. But there is a Instagram video. It's a just real brief kind of explainer video, but I linked to it in the article and you might consider linking it directly in the show
I can
notes.
put it in the show notes. Yeah.
Perfect. By Dr. Naomi Whitaker, who is NAPRA trained and a restorative reproductive health
She's
professional.
phenomenal.
She specializes in endometriosis. And she explains why specifically diagnostic laparoscopic surgery is the gold standard for diagnosing endometriosis. And she explains very carefully, but very in a way you and I can understand why imaging is insufficient to make a for sure diagnosis. So that is the bridge into this next point, which is they're acknowledging in the guidelines that the evidence is not high quality for the recommendations they're making. And then they're recommending things that restorative reproductive medicine professionals who specialize in endometriosis know are inadequate. But the biggest miss from the guidelines is this idea that they did not tap restorative reproductive medicine professionals for these
Yeah.
guidelines development to be able to say, you guys have been way ahead of the curve as far as recognizing all kinds of things, as far as treating endometriosis from root causes for decades now. But their voices were not brought to the table. And that's the biggest disappointment about ACOG's new endometriosis guidelines.
Yeah, yeah. Okay, I'm so grateful you just laid it all out because that was really, really helpful. Now, I want to point out that your article says is titled "Wins and Misses," but what I'm hearing from you is that really, and again, correct me if I'm wrong, but like the only win from this change from ACOG, from whatever the standards were beforehand to what the standards are now as of this new practice bulletin, is that we're looking at it in teenage girls rather than expecting for it to start later. But is that, which is a huge win. Like we cannot discount that. Like that is a huge win because there's so many teenage girls that have painful periods that have, I mean, I am one of those that had, you're talking after 2 years after puberty, you continue to have these irregularities. The first 2 years is pretty typical because your body's trying to figure out what the heck it's doing. But after that, it should get in the rhythm of things. But if it doesn't, that means that there's an issue. And typically, a woman will just be put on birth control. Again, that was me. And so, but what you're saying though is that the win here is that ACOG is looking to diagnose earlier.
Yes,
Are there any, before we like dive into all the other things you said about the things that it misses, are there
sure.
any other wins that you can see here with this change that ACOG has made?
Sure. I would say this is a smaller one, but one other win is that they recommend against using any type of blood or a urine test or any other biomarker to diagnose endo. And even though that recommendation is based on low quality evidence, that is supported. What they say is supported by, again, this is a Instagram post that's linked as well from Dr. Naomi Whitaker, but she acknowledges, she agrees with this point. We should not be using blood tests, urine tests, or any other biomarker, like human biomarker, to diagnose endo because there just isn't research behind those things. There is nothing that is evidence based that we can use to diagnose endometriosis that is some type of a test you could have drawn in a lab.
As much as that would be amazing.
Right.
As
We
much as
would
that
love
would be
and
lovely.
honestly
Yeah.
about every 6 months there's something on Instagram where it's like, "Okay, we've found the thing. We found the thing." And then as it turns out, "Oh, but no. Oh, but no." And so though I would say that's another win, is recognizing that you can't diagnose it with a test that somebody can go and have done in a lab. And I will say this as well, that I didn't say this before, but it's just adding on to what I said. The benefit of getting endodiagnosed in teenage girls is not simply for fertility. The preservation of their fertility is important, but I also want to be clear that the other benefit of that is that we potentially, hopefully, are saving women starting young from a young age. We are hopefully saving them years and years of pain and being dismissed. Right. There's an article that came out, and I can't remember what secular publication it was sometime in the last couple of years, but it was essentially like so and so wasn't sick or excuse me, wasn't like faking it. She was sick. Like she had endometriosis. So the symptoms that she was reporting that they just weren't able to find a cause for, they were not in her head. And that is a benefit too. If we can acknowledge endo in young girls, we can stop telling them nothing's wrong when in fact something is.
Yeah. Yeah, and that's a huge point, and that's a great point. So that's the win. That's the biggest win for is
Right.
that the younger age girls are now being seen, and they can be
Yes.
seen earlier and be heard. And so, and actually, I mean, even though they're not as dedicated to giving better guidelines for treatment, diagnosis is still important. Diagnosis is
Yes.
important for proper treatment. So,
Yes, it is.
right. So we're okay. So that's great.
And especially
Let's
because specific to endo, and you already know this, but I'm just going to put this out there to be
sure.
very
Yeah.
clear with all of the listeners. The average time from onset of symptoms to diagnosis is insane
Like
for
10 years.
endometriosis. It's somewhere between, depending on the study you look at, 7 and 12 years. And I just
Wow.
can't think of another condition that we would have 7 to 12 years worth of symptoms, no actual diagnosis, and therefore no proper treatment for it. And that just would be an acceptable status quo. So, yeah, that's just a little bit more context for, yes, why it is
Yeah.
important and
Yeah.
valuable.
Yeah. So now let's cover the misses and like what does ACOG miss about properly diagnosing and treating endo? One thing you said that really that struck me was just in the way that that endometriosis is diagnosed. We cannot
Mhm.
diagnose with the blood test. We cannot diagnose with the urine test. And what Dr. Naomi Winokur from the Instagram reel that we will link in the show notes. She makes a case for you can't even properly diagnose endometriosis with an image. You must have a diagnostic laparoscopy surgery to properly diagnose and treat endometriosis. So, what does ACOG then have to say about that in this new guideline for properly diagnosing endo?
They acknowledge diagnostic laparoscopy, but they are not saying this is the gold standard. And this is not
Mm.
something that they say in there as well, but just from other places and spaces that I've read, it's really difficult to get proper insurance coverage for a diagnostic laparoscopic surgery. And if I understood correctly what I've read other places, doctors may not get appropriately compensated for that surgery. And who is going to want to do procedure after procedure after procedure that you are not able to make um, adequate? I don't even mean like making the big bucks. That's not what I mean. But if you're not able to be properly compensated for a surgery that could take you quite a long time, because especially if you're a NAPRA trained doctor or restorative reproductive medicine trained doctor, you're going in, you're diagnosing, but what else are you probably doing at the same time? Treating, right? Because you're not just saying, oh, well, I'm going to diagnose it and then I'm just going to leave it all exactly as it is. Hopefully, the doctor that's taking care of you knows what to do and is very skilled and does many, many, many of these procedures and can get rid of the endometriosis for you. But then now it's no longer just a diagnostic surgery. It's potentially taking hours and hours and hours. And so that is not something that the listener can do something about. But, and I'm not saying it to scare people, but just to put a little bit of reality injecting into the situation to say, let's also remember that it is going to be difficult to acknowledge a gold standard treatment that is not being adequately compensated for the physicians who are skilled enough to perform it. Um, but so that's, yeah, so there is acknowledgement of diagnostic laparoscopy in the guidelines, but it is not what they consider your first line approach. So they're not dismissing it, but they're also not preferring it.
Do they consider first line approach to be imaging, like ultrasound imaging to diagnose endometriosis?
They are, let's see, because I wanted to be specific about this. They write that a
Yeah.
laparoscopy can be considered in patients with suspected endometriosis to confirm the diagnosis, even if the results of a physical exam or imaging are negative. However, diagnostic laparoscopy is not required to initiate empiric medical treatment. And then they also wrote, and I'm going to unpack that in just a second. They also wrote additionally that during a diagnostic laparoscopy, a biopsy should be considered, but a negative result does not exclude the possibility of endometriosis. And finally, suspected endometriosis lesions should be treated at the time of initial laparoscopy when possible to help avoid the need for additional surgery. And this is exactly what I was saying just a minute ago. You're not just going in and diagnosing, you're going in, diagnosing, and treating all at once. And are you going to be able to How are you billing that from an insurance perspective so that this diagnostic laparoscopy, which is now a treatment laparoscopy, gets compensated? But the line that I want to return to before that is, however, diagnostic laparoscopy is not required to initiate empiric medical treatment. And let's just be real clear here that empiric medical treatment is referring to hormonal birth control. And this is something else that I'm just going to put on the table. For years and years, ACOG's position, the mainstream conventional medicine position, has been if you go into the doctor's office and you have painful periods or acne or irregular cycles or any number of symptoms, you are walking out of there with a prescription for hormonal birth control. And in some ways, that's what that's what the guidelines are still saying. Maybe now we're calling it endometriosis, but we're treating it the exact same way we would have if we didn't have any label for it other than painful periods, heavy bleeding, irregular bleeding.
Yeah, and it just reminds me of I had an NFP client. This was years and years ago. It was a marriage prep NFP client. And in the Diocese of Phoenix, back then at least, full NFP course was required. So no matter if they were taking the pill or if they wanted to use NFP or not, they had to go through the whole NFP class. And so I was teaching this couple, and I remember this couple so specifically because I would always give like a gentle, like, hey, when you're on the birth control pill and you're charting your cycle, because charting was still required, whether you were on the pill or not. And I loved that because they could see exactly what the pill was doing to their body, because their chart did not look like how, like, the examples looked like. And I'm like, yeah. And I would actually be surprised if it did, if you were on hormonal birth control.
Mm-hmm.
And so anyhow, I was having this conversation with this woman, and she was on the birth control pill for her endometriosis. Had she had a diagnostic laparoscopy, I always butcher that word, diagnostic surgery to see if she had endometriosis? I would assume not. I'm just assuming not.
Sure.
So whether or not she actually had endometriosis in the first place, that's questionable. But then also she was on hormonal birth control, as what her doctor said, to help with her endometriosis. And I mean, I'm just a little NFP teacher, so she's going to, of course, go with her doctor over this girl that's teaching him NFP that I'll know for 10 weeks. But it's just, I just wanted to shake her and be like, this is not helping you. Like,
Right.
absolutely, maybe it's helping your pain, but the second you get off of it, your pain's going to come screaming back because the endometriosis is still there, if you even have it in the first place, if that's what's causing the pain. So there's just so much confusion around the treatment being hormonal birth control. I mean, yes, it's
Mm-hmm.
symptom suppression
Mm-hmm.
sometimes, not even
Mm-hmm.
always, but sometimes.
Not always.
But it's like bottlenecked. You can change all that you want in the beginning to properly diagnose. That's great. But if the end result is still birth control, why are we even having this discussion?
Sure.
So yeah, so I find that interesting that, as you said earlier, the diagnostics are starting to change, but the treatment isn't catching up.
Yeah.
And yeah, so I find that interesting. Now, one thing that I also want to get into is, you said how in the practice bulletin, if somebody has um, a negative biopsy, like if they had a biopsy or they had some sort of imaging with some sort of testing happen and it
Mm-hmm.
comes back negative, it doesn't disclude them from still having endometriosis. Like, that's still a possibility. Well,
Right.
what happens when the flip side occurs and maybe the doctor, based off of an image, the doctor does say, oh, you do have endometriosis. And then maybe they go in and it's not actually there. And the only reason I say this is because I had a client who had a surgery. This was not from a NAPRO trained doctor. It was somebody completely outside of restorative medicine. But she had an ultrasound to look for endometriosis. They thought they saw endometriosis on this image, and so they went in surgically to remove it, and it wasn't even there. So I'm
Mm.
wondering just how often that might occur too when when the diagnostics are still not up to par.
I will speak in a very limited way about that because I
Sure.
don't have much knowledge about that. One thing that actually comes to mind as you're saying that is, from what I understand, if you are not a doctor who routinely does diagnostic laparoscopies, it is possible for you to miss endometriosis that is there. Now, I do not have any statistics for you, so I will not pretend to you that I do, on how often you might suspect endometriosis based on imaging, and then you go into surgery and they can't find anything. But my understanding is that there are specific types of surgical techniques. One is called MIGS, I think, and I can't remember what that stands for. I cannot remember what that stands for, but there are specific types of near contact surgery that restorative reproductive medicine trained doctors are utilizing. And those same techniques are not being utilized by your doctor in your hometown. So that's all that I will say about that, is that it may be possible that somebody thinks you have it and then you go under surgery and they don't find any evidence of it. But from what I understand as well, you have to do high volumes of these surgeries and be very experienced in all of the different ways that endometriosis can look in order to be able to say, oh, yes, that person for sure doesn't have it. Does that make sense?
Yeah, no, it absolutely does. And I'm even thinking now, so I shared this with you before we started recording, and as of this recording being released, I will have shared with all the listeners as well that I just had an ovarian wedge resection, which it has been perfected by NAPRO technology, the surgery, to help with PCOS, and really the golden effect of this being putting it in remission. So I just had that surgery. And so Dr. Erica Kreller in Phoenix, Arizona, it was my surgeon. She was so phenomenal. Honestly, I mean, any NAPRO surgeon is great, but she's like the only one that I would trust to touch my ovaries. Like I just, she also delivered my third kid. So I'm like, you've seen it all. She's great. But anyhow, so she did the ovarian wedge resection. And so that's basically, for listeners who aren't aware of that or don't know what that is, with PCOS, oftentimes your ovaries are enlarged. And so she takes, think of like a pizza slice, like a pizza or a piece of pie wedge out of your ovary and then sewing it back together. And it helps with hormone balancing. And anyhow, I have I'll link all the things below. I have a whole episodes on that. But with that, 50% of PCOS patients also have endometriosis. And so when I was talking with her about the surgery before I went in, I was asking her about this, and she said, well, she actually didn't suspect that I would have endometriosis, but she still was like, I'm going to look for it. And if we see it, we're going to cut it out, like that, hands down. And I just had my post-op appointment earlier this week. And it was really, it was so cool. And maybe some people wouldn't have liked this, but she took a video of everything, and she moment by moment walked through the video of the surgery with me. And as I'm looking at this, I literally thought to myself, there are hundreds of women that I know who would love to be sitting in this room right now getting this play-by-play. But I did have endometriosis. It was minor, but so she ended up cutting out quite a lot and I asked her, I'm like, was there really that much endometriosis? And she said, no, but anything that may even resemble or look like it possibly could be endo, I'm going to remove. Now, there were two main spots that were for sure after, especially like they send it to, they send the tissue over to be tested after the surgery. And there were two main spots that did come back positive as endometriosis. But I mean, she cut out a lot to just everything that she thought could possibly be endometriosis. And so, and I'm just so grateful for that. I'm so grateful for that kind of treatment. And I'm finding more and more women are, as they learn about NAPRO technology, as they learn about charting their cycles, as they learn about why birth control isn't the best option, as they learn and just discover more about how much they don't they have not been taught about their bodies and what medicine is actually up to par in treating them if they do need treatment.
Mhm.
And of course, like not everybody is going to need surgery, but especially for endometriosis, there is such just among the medical community, I think there's just so much confusion around how do we properly diagnose this? And then even if we do get a proper diagnosis, how do we properly treat this? And what we're saying and what we would argue is on the stance of naprotechnology being you need the gold standard is a diagnostic surgery, and then right then and there, if they see it, they remove it. Um,
Yeah,
and
and
so
let's be
that
clear
really
about
yes,
what we
please.
mean by
Yeah.
removal, okay?
Thank you. Yeah,
We
yeah, get
don't
into that.
we
Yeah.
don't mean ablation surgery, which is where you burn or you cauterize off the surface. I've seen graphics that can maybe help explain this, and one is the example of an iceberg. You can scrape the ice off the top of the surface. You are doing absolutely nothing for what's underneath. And so this was a miss as well from the guidelines that ACOG released, was the failure to recognize that excision surgery, which is where you go in and remove as much as you possibly can. And this is again a point where it's so important that you find a physician who is trained to see every single possible appearance of endometriosis, like the doctor you're talking about, and then who is trained to remove it, not to burn it, because when we burn it, it comes back. That's why it's a problem. Your recurrence rate, your recurrence of pain and other symptoms within just a few years. I'm not even talking 5 and 10 years down the road. I'm talking your recurrence rate within 2 years is unacceptably high when all you do is burn. When you excise, when you go in and remove, you can picture scraping out, you can picture whatever you want, but actually removing all the tissue, not just skimming the surface, then you can see very different. Yeah. Oh, go ahead. I'm sorry. I've lost your audio.
I was on mute. That's why.
There we go. Perfect.
Sorry.
Go right
There's
ahead.
like some trash cans rolling out there. I'm in my husband's office. And so I'm like, I don't know if that's in the background. Anyhow, I literally saw her in the video. She like pulled I don't know if it's the skin or the tissue, whatever it is on the inside of my abdominal wall. She pulled it and then cut it.
Yes.
Like there was an actual cutting it out. And then
Yes.
I saw like the little tools and she's doing this all robotically too, which I'm just like, this is so amazing.
Yes.
But I just saw the little robot hands pull the thing, cut it, and then that's the tissue that she took to get tested to confirm it was endometriosis. So it was completely cut out. It was not just burned.
Yes.
So that's huge. Yeah.
Yep.
Does
So
it?
sorry,
So
I
it
cut you
says
off, but
that.
I just wanted to make
No,
that
you're
distinction
fine.
that
Yeah.
we're not talking ablation surgery. We are talking excision surgery if we're going to try to get rid of the endometriosis specifically.
Yeah, yeah. What are some other so we talked about the wins being okay, early detection for younger women, for teenage girls. We've talked about the misses mainly being okay, the treatment itself has not really changed really all that
Yeah.
much.
Yeah.
Even the diagnosis itself is still allowing for subpar diagnoses processing
Mhm.
rather than the gold standard of actually getting in there a trained surgeon going in there and excising it. Is there what other misses can you think of, or maybe we can go into how hormonal birth control, maybe why ACOG still sees that as the gold standard treatment. Do you have any thoughts with any other misses or talking about birth control still being the main treatment here?
Two thoughts I would say that I want to put out there. One is that empiric medical treatment primarily refers to hormonal birth control, but there's actually also another type of medication that was marketed as the first endometriosis specific medicine or specific pill, I believe. And it's ORILISSA, Orilissa, I assume. But
Okay, I've
that
never
is
heard of it.
considered an endometriosis treatment specifically for endometriosis, not off label, so to speak, with hormonal birth control being given. But the thing that needs to be discussed here, and this is another Natural Womanhood article that we'll link, I'm pretty sure I wrote it, was that it puts your body into a menopause like state. So you are putting 25-year-olds, 35-year-olds, 40-year-olds into the hormonal state of a woman in menopause
How is that different than birth control, though?
because the extent to which it does everything in menopause levels, those are like bottom of the barrel. And if you think about hormonal birth control, right, instead of shutting off all hormonal input, you are still taking your pills, right, for 21 days and then 7 days of placebo is one example, right? And so this is another fascinating thing that recent research has shown. We thought that hormonal birth control, right, just like flatlined your body's natural production of estrogen and progesterone. But what's interesting is the research now suggests, very recent research suggests that actually it rebounds if for estrogen, it rebounds during that week of placebo pills and then starts to go back down again as soon as you go onto the active pills. But your body's progesterone production actually doesn't really do that. Not in the research. Even during the week off, your body is not really rebounding there. But if you are taking Orilissa, you are withdrawing all hormonal support and suppressing the body's natural production as well. Whereas hormonal birth control is giving you, I'm doing the quotation marks for those who can't see the video, it's giving you some synthetic, some not natural to your body, not chemically identical estrogen and progestin, a synthetic progesterone. And so we're giving you something, but Orilissa is just taking
Just flat
all of it away.
lines.
And so then you start to see
Wow.
these very significant results of bone density loss, right? That's not necessarily going to be reversible at a time in life, especially in your 20s, when a woman should be hitting her peak bone density mass. So that's just one thing I wanted to put out there as well, is that Orilissa is also considered an endometriosis medicine, but it is equally concerning from a health and side effects perspective
Yeah.
as
Is
hormonal
it
birth control would be.
only like, is it a medicine specifically for endometriosis?
That's the
Like,
way that it's
it is only
marketed.
for that? Is
Yeah.
it as as the way it's marketed, is it supposed to remove your endometriosis or just maybe stop the growth of the endometriosis? Like, what is the main what is it supposed to be doing?
It's supposed to prevent it from growing, but if you look at the page, like the marketing page, it really just says it's the pill that will help. It doesn't
So does
make major
ibuprofen.
claims about, like,
Yeah.
how it's going to help you and how it
Hmm.
works exactly. The patient-facing
Wow.
page for Orilissa is very pink, but also very much lacking in education on, like, this is how it's even supposed to help you. But I'll get you the link for that as well so people can look into the
Yeah.
side effects and how that works if they would like. But so that was the first thing I wanted to acknowledge, that empiric medical treatment is going to be hormonal something, whether it's hormonal contraceptives or this or Alyssa. But then the
Can
other
I
thing, oh, go ahead. Yeah, yeah.
No, I was just what is empiric medical treatment? What does that mean?
So empiric medical treatment would be based on experience. Like, this is what we think works.
Okay. So they don't know, it's not based on any scientific research study, solid studies. It's just an experience of giving this sort of treatment. We found this to help.
Yeah, it can be backed up by research, but what it mostly means is this is how it's done. This is how things are done. This is the
Okay.
standard way that we treat this. Um,
Okay.
so, however much research there is or isn't behind that, but this is typically how we respond to X with Y.
Okay. Okay. So you're saying, so that was another huge miss, obviously, and that those treatments being hormonal birth control or just completely shutting off your hormones altogether. Now, you were saying earlier there was one other thing you wanted to mention.
Yes. Oh, just that when you are missing the input of restorative reproductive medicine trained professionals, you're missing recommendations about other things like supplements that may be helpful to women who have endometriosis, like N-acetylcysteine and low dose naltrexone. Those are other articles in Natural Womanhood, but there has been some research linking those things to an improvement in endometriosis symptoms in women, whether they are waiting for a surgery to happen or after they've had surgery to um, help with any symptoms that are residual. And those things, there's just no mention of them at all in the guidelines.
Mm.
So we're depriving patients of access to things we know can help some women, not all, but some.
Yeah. I know this opens up a can of worms, but why? Why isn't ACOG recognizing experts in restorative reproductive medicine and NAPRO technology? Why aren't they recognizing all of the research that's been done on that side of the coin?
That's a great question. I don't know if I want to speculate too much on that because it would be
Sure.
easy for me to just say, well, because of big pharma, there's nothing behind restorative reproductive medicine trained professionals that's going to be equally financially lucrative, right? We just said earlier the insurance is not great for getting these procedures covered at what the physician's expertise is worth, right?
And time.
So what and time. So what motivation do they have to recognize these things that at present would represent a major sea change from how we have done things before? So without trying to speculate and kind of like wag my finger when I don't have specific evidence pointing to like, here's an email exchange where they said,
Sure.
well, because we're getting paid money, like I don't have any evidence of that. So I don't want to point fingers and explain why that is, other than to simply say there is financial incentive in using medication like hormonal contraception or like an Orilissa, right? That you just aren't going to match if you are saying, we love restorative reproductive medicine and we think that it should be practiced widely and everywhere. But I will say that ACOG is perfectly fine with abortion. They are perfectly fine with hormonal contraception as a band aid treatment for all sorts of conditions. And so, what's necessary, and what I do see slowly happening, what's necessary is for patients to continue to insist and ask questions and advocate for themselves and to say, what else do you have to offer me? What else do you have to offer me? So when they go into their doctor's office and their doctor says, well, based on whatever symptom you have, hormonal birth control is the answer, then the automatic next step for the patient needs to be, what else do you have to offer me?
Yeah. And honestly, that is, I think we're entering into a new phase of culture where more and more people are willing to ask that question, which I'm so grateful for. And I even know this because of I get DMs on Instagram even of women that are typically on average in their college years, either
Mhm.
stating about themselves or their roommate or their best friend or someone that they know who has only ever been offered hormonal birth control for whatever they're experiencing. And they either just don't want that because they don't feel good on it, or maybe they feel worse on it, or they know they're starting to learn and they know that this is not the treatment that they should be receiving. It's not. And so I point people to natural womanhood all the time. I point people to NAPRO, I point people to FEM, I point people to facts about fertility. I mean, there are so many good people doing such good things in this realm. And it's interesting. I was just doing some research for another episode that I did, and where I was looking, I just did a quick Google search on, I'm trying to think of exactly what I put in there. I think it was just like restorative reproductive medicine. Yeah, something very simple like that. I Googled, and the first thing that came up, the headline was, why the term restorative reproductive medicine is dangerous for medical care. And I just wanted to rip my hair out. I'm like, first of all, why is this the first thing popping up? Second of all, what is going on? Like, what is going on here?
Well,
There's something.
they have been, I'm thinking of this now. I wasn't thinking of this 2 minutes ago. I'm thinking of
Sure.
this now. They have been actively dismissive of restorative reproductive medicine. You can go back, I'll try to see if I can find it and send it to you. But there was a post. They got massive blowback from our supporters. But you know what I'm talking
I
about?
remember.
Last year,
Yes. What was
there was
that
a post. It was
about?
like last summer, I think, and they
Yeah.
they released some type of press release or a document that was talking about restorative reproductive medicine, very dismissive. And it was saying, this is just basic standard care. Like, this is what every woman already has access to when she goes to her doctor's office. There's nothing special and nothing to see here. And they said women who go down the path of restorative reproductive medicine may get delays in treatment. This was something else too that actually this came up because okay, this is all coming back to me now. Because last year, do you remember there were all the hearings on Capitol Hill about how
Yeah.
much support the administration was going to have for IVF? And ACOG and others were saying, well, if you're not backing IVF, then you are just wasting women's time who are going to end up with IVF eventually anyway. And that was the way that they were couching it. They were phrasing it as restorative reproductive medicine is going to waste your time on surgery
It's like a
just to get
distraction.
to this same place of you're going to have IVF to conceive. Okay. Yep. So, yeah, I was going to give them the benefit of the doubt, but I guess based on their own, I was like, well, I don't have evidence of that actually. Yeah, actually we do.
But yeah, we do. We
Actually we
do.
do.
Yeah.
They did not prefer restorative reproductive medicine. Yeah, that's
Yeah.
true.
Well, and I think also there's this taboo idea too that it's religious and so therefore it should just be completely um abandoned.
Sure,
And
yeah,
as
it couldn't
much
have any relevance for a secular
yeah.
patient.
And this is why I love restorative reproductive medicine because from a religious, I mean, you and I are both Catholic, so from a religious standpoint, yes, absolutely. It totally lines up with everything that we believe in our moral framework. But like you can completely set that aside and still realize like when you dig into what hormonal birth control is actually doing to women's bodies, how it's not healing the root cause, why endometriosis actually can get worse in the background when a woman is taking the pill, and yet it's still being told as this is the first line treatment.
Right.
Like you can completely scientifically unravel that too
Mm.
and get to it from a completely factual, not to say religion isn't factual, but a completely scientific understanding of it. And that is what I love. That is what I love about it because faith and reason go hand in hand. And that's, yeah. I am getting on a soapbox that I need to get off, but I just, yeah, I really hope and pray that one day this will be seen and taken more seriously because it is helping so many women, so many
Mhm.
women. Yeah, and
Yeah.
everything Natural Womanhood is doing, everything that Facts About Fertility is doing, everything that NAPRO and FEM and all of the neo-fertility, all the restorative reproductive medicine providers are doing are just letting women have a breath of fresh air and realizing there is something different out there. There is something else that I can try that actually will help and get to the root
Yeah.
of what is happening.
Yeah.
Yeah.
And just
Yeah.
acknowledging to women, honestly, like you said about the risks as well of hormonal birth control. This is not to do with endometriosis, so I'll keep it very brief. But when I gave birth, my bleeding pattern was pretty irregular and heavy afterwards. And so my OB, of course, was gone. She was on safari. She was unavailable, like unable
How
to be
dare she?
reached. And so I went to see one of her partners, and this is the first time in my life. I was 35 years old when I went into this office appointment. This is the first time in my life that somebody flat out just said to me, "Okay, well, your first treatment option is birth control." I just looked at her and I was like, "What are you talking about? I'm postpartum 10 days." And she's like, "Well, it can
Wow.
thin the lining of your uterus and help the bleeding, like it can help you get rid of the bleeding more." And at that point we didn't think that I had retained placenta. Uh but it was like we weren't even totally sure on what the cause was. And she's like, "But we'll just give you birth control." And I was just dumbfounded because it was completely casual. There wasn't a syllable of birth control can be helpful to do X. It can also do Y and Z and da 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 da. Like there was just nothing. There was just
Hmm.
nothing. And in that moment, I just thought, this is what women all across the country experience every single day, where there's just like, oh, well, here's what we could do for that. And so I did push back and I was like, no, I don't. Yeah, no, I'm not going to do that. No.
Did she give you any issue? He or she give you any
She was
issue?
just sort of like, okay, well, we can keep waiting. And then her second suggestion was mifepristone, which is the abortion pill if your baby's alive. If your baby's gone, it's acceptable to take that medicine for potentially to help with the bleeding, but also it can cause hemorrhage. So it
Well,
was just
that's
like, neither
fine.
of the options that you're suggesting to me sound really great. And you didn't give me a single thing to think about for either one as to
Yeah.
like, okay, here's the potential benefit, but you should also know as an informed consumer, you should also know what the potential problems with it are. And even when I just spoke up to her and said, "Oh, yeah, I'm familiar with mifepristone in the context of abortion, and I know that it can cause hemorrhage, and I'm really not interested in that. I'm already bleeding too heavily." She just kind of said, like, "Okay."
If you don't mind me asking, what did you end up doing?
I just waited. I waited
Okay.
longer, and it took a very long time to resolve, but eventually the bleeding did slow down. I needed
Mm.
to pass a couple of much bigger clots, and until I could, I just bled and bled and bled and bled low level. And then finally it was like I cleared a little bit more of the heavy bleeding, and then after that it really did resolve well. But I say that not to take attention away from the importance of talking about endometriosis, but just simply to like put a little point, I guess, on the conversations that aren't happening in the average OBGYN office in Anywheresville, America right now, and how these guidelines don't necessarily move us much closer to an improvement other than, like I said, the value of earlier diagnosis,
Mhm.
which just leaves the onus on us as patients to continue to say, what else do you have to offer me, until we're able to get to that place where we are getting evidence-based diagnosis, we are getting evidence-based treatments, we're getting the full recommendations in terms of things like supplements is one example, and where restorative reproductive medicine trained professionals are brought to the table and treated as equals.
Yeah. Yeah. Anne Marie, thank you so much for being on the podcast today and sharing your wisdom. This is exactly what I wanted. Like I saw your article and I'm like, you need to explain everything to me. And you did that beautifully. So thank you so much for taking the time and being on the podcast. If somebody, are you on Instagram or socials or anything like that? Like
Oh
if somebody
gosh.
wanted to find,
Uh,
well, you have your podcast. You have
yeah,
your
so I
podcast.
would
If
send
somebody
them.
wanted to find you, yeah.
Yeah, I'd send them probably to the postpartumonpurpose.com, just to that website. I have Instagram, but I just do very little with it. I just do very little with it. So it's at postpartum on purpose on Instagram, but really I put most things onto the website and have a little blog where I do like show notes, but then extra things like other episodes that are related to this and all of that. And then if you just go to naturalwomanhood.org and look, like you'll see one of my articles somewhere, and then if you just click on my name, it pulls up the other 115 or whatever.
That's great.
They're everywhere.
That's amazing. That is amazing. Thank you so much. Thank you. Thank
Absolutely.
you.
Thank you.